I should declare an interest. I co-chair the International Steering Committee for World Kidney Day, which is a public health awareness kidney day. And one of the sponsors of that is Danone Research. You should know that. I'm going to declare another interest. It's a confession, really. I only ever failed one exam in my life. At the end of my first year at medical school, I failed renal physiology. And the reason I failed it was because I couldn't explain the countercurrent mechanism in the loop of Henle of the renal tubule. I still can't. Luckily, Peter and Richard are here, and they can, and we'll ask them later about it. I made this slide yesterday, and I'm rather glad I did, because I knew by this stage of the day we'd still be struggling with the 4 H's. I don't yet know what hydration is. Are we talking about water? Are we talking about water and solute? What are we defining? In fact, most of the time in clinical practice, we're much more concerned about hypovolemia. In other words, the reduction in effective circulating volume, and that's the homeostatic priority. And although we've begun to talk a little bit about hyponatremia and hypernatremia, I think they're terms that are very often misused. So the term hyponatremia means that the concentration of sodium in the serum is low. You can have that and be grossly fluid overloaded or grossly fluid underloaded. So we shouldn't confuse those terms, and I just thought we should get that out in the open. So the kidney has a major role in the control of extracellular volume and body fluid tonicity. And we're well aware that we have about 40 litres of body water, but of course the focus here is very much on the maintenance of blood volume, which is only about 10% of our total body water, but that's our priority. And to maintain effective circulating volume, I think Larry told us earlier, we have a lot of mechanisms in play. So there are many afferent mechanisms which sense volume. I'm not going to go through them. There are many efferent mechanisms which control volume mainly through the kidney, and I'm not going to go through them. I'm merely making the point that this must be extremely important because we have a very complex set of control mechanisms designed to maintain circulating volume. And the kidney has a major role in maintaining body fluid tonicity. And on this slide, just to remind ourselves that only when our serum osmolality gets above about 290 does thirst begin to play any role. Before that, we control tonicity on the basis of increasing vasopressin levels as necessary, driving up urine osmolality until that begins to plateau. And the point which Richard made earlier on of this remarkable variation, near tenfold variation we can achieve in urine osmolality. A remarkable degree of variation committed to maintaining circulating volume and circulating tonicity in a very small reference range. And I think from a practical point of view, for me as a kidney doctor, I would say that the kidney has a major role in the control of volume and tonicity, and in almost all circumstances will prioritize control of volume. Because if you don't have a circulating volume and you don't have a circulation, you're in terrible, terrible trouble. And it will prioritize that against prioritizing tonicity. Now, I didn't plan to do a physiology talk, but let's just remind ourselves that the tubule is concerned in the proximal part with gross reabsorption of sodium and water from a very large filtered load, and that as you go down the tubule, you do more and more refining of serum content, so that in the sodium content, so that in the end you're typically peeing out only about 1% of that which you have filtered. And a series of different transport mechanisms for sodium are effective in different parts of the tubule. And the details of that I don't think matter for us today. Tonicity almost exclusively controlled by vasopressin, which is mostly in the collecting duct and a little higher up where there are vasopressin receptors. And we'll come back to that in a minute. The next point I wanted to make was that we can put people in isolation and do kidney studies in healthy people sitting in a lab, but most of the time, when the kidneys are struggling, then people are struggling for other reasons. And it's very difficult to separate the kidney element of homeostasis or failure of homeostasis from everything else that's going on. There are all sorts of other factors at work. There'll be inflammatory responses in sepsis and burns. There'll be the response to surgery, which Ahmed has just been talking about, the effects of general anesthesia and hypoxia, of heat or of variations in muscle metabolism or of variations in eating disorders. So in the real clinical world, very difficult often to separate exactly what the kidney is and is not doing and how it is and is not failing because of the complexity of the clinical setting. And the other point I wanted to make was about what I've called the variable renal response to salt and water depletion. You might imagine that kidney doctors would be pretty good at predicting, on the basis of what's happened to the patient's fluid balance and their circulation and their input and their output, of knowing what the answer is going to be in terms of what the serum sodium concentration is going to be, for example. I think it's remarkably difficult to predict. You can walk to the bedside and be confronted with a serum sodium of 115, very low, and see a patient next to them in which apparently the same thing's happened and their serum sodium concentration is normal. So I think just another pointer to the complexity of the control mechanisms and the complexity of the other metabolic challenges that face us in clinical practice. And also just to remind you about what happens to the kidneys if substantial volume depletion is not promptly reversed. There's an appropriate renal response to volume depletion. We will reduce sodium and water excretion. We will become oliguric. We will protect intravascular volume to protect circulatory integrity. Primary mechanism. But the effects of sustained volume depletion are that you'll get acute renal ischemia. And you won't necessarily have overt circulatory failure for that to happen. And if that is not reversed, then you go on to get a type of ischemic tubular injury, which is usually called acute tubular necrosis, which is a reversible form of acute kidney damage, which will usually be got better in days or weeks if the patient survives whatever else is going on to them. So clearly this is the most serious end of the way the kidney will be challenged in a complex clinical setting. And if you have an illness which gets you into hospital, which results in you having acute tubular necrosis and acute kidney failure and your kidneys stop working, your mortality is 50%. Yeah, 50%. Half of them are dead. Whatever those, if you average all those circumstances together, reflecting the severity of illness which provokes acute tubular necrosis. So, having thought about those general things, let me try and answer a series of questions which I think were the ones we ought to try and answer. What are the main factors that determine the kidneys won't maintain the internal milieu even if there's normal intake of salt and water? How could that happen? So in other words, what extra-renal problems could there be in people with normal kidneys which will get them into trouble? And we've mentioned it already, and the number one is medications. So things that alter your renal response to vasopressin or modify your sodium excretion potentially get you into trouble, even if your kidneys otherwise are normal. And most commonly that's diuretics and the non-steroidal anti-inflammatory drugs. There's a syndrome of inappropriate vasopressin or inappropriate ADH secretion, which happens in a wide range of neurological and respiratory disorders. So your kidneys are normal, but something goes wrong with your osmoregulation. You have too much vasopressin in the circulation, and you end up with concentrated urine and hyponatremia. And that's a not uncommon problem on medical wards. And just for a rarity, just because I was thinking about it, there's a phenomenon called cerebral salt wasting, which often happens after brain hemorrhage. And here there's a double problem. You get an increase in renal sodium loss, and you get increased vasopressin release, and it's probably due to release of one of these brain natriuretic peptides. So just examples of things where the kidneys are fine, but they're challenged from things outside the kidneys. What are the main factors in determining that the kidneys will no longer maintain the internal milieu at lesser extremes of salt and water depletion? So I'm just thinking of if patients are admitted to the hospital fluid depleted, what are the things which make them more likely to get into trouble than other people? We've already begun to discuss some of those. And in apparently healthy individuals, I think the first point I'd make is about neonates, which we began to discuss briefly. So neonates are intolerant of sodium loading. They're intolerant of negative sodium and water balance because of tubular immaturity, to put it simply. Peter will, I'm sure, give us a much better explanation than that. And the other people are older people, apparently completely healthy older people, because what happens as you get older is you get less good renal tubular function. And in effect, your tolerance windows close in. Your tolerance of sodium depletion or overload, your tolerance of water depletion and overload, of potassium depletion and overload, or of acid load, all get narrower, and you're more likely to get into trouble, particularly if you're one of those many older people who take the drugs we've already been discussing. And what about people who've already got abnormal kidneys? What circumstances are there which aggravate their capacity to maintain the internal milieu? Well, firstly, although very rare, there are some monogenic tubular disorders which result in mutations in individual transport mechanisms in the renal tubule, which modify handling of sodium chloride and water. And the best known of those probably is so-called nephrogenic diabetes insipidus. In other words, it doesn't matter how much vasopressin you have in your circulation, your tubules don't respond. You have obligatory polyuria, and unless you get a lot of water, you're in trouble. And there are also some transporter mutations which modify the way the kidney handles sodium, and some of those predispose you to sodium wasting. But from my point of view, the people I worry about are the people with chronic kidney disease. Not people whose kidneys have failed completely and are on dialysis and don't pee, but people who have impaired kidney function, whatever caused that. Because as your number of nephrons reduces, your ability to concentrate the urine reduces, and you end up with what's often called isosthenuria. That is to say, your urine osmolality is the same all the time, whatever anybody does to you. And the consequence of that is that these people are at risk from sodium and water deprivation, but they're also at risk from sodium and water loading. And they're very bad at controlling their extracellular volume or their tonicity at either extreme. And as kidney function declines, this gets worse. So these are people who are my day-to-day challenge and who need a lot of clinical care. Does acute and recurrent underhydration cause irreversible kidney damage? Can you actually damage yourself by not drinking enough? Well, you might imagine, wouldn't you, that weight-categorized athletes like boxers and jockeys might be the people at risk. Recurrent rapid weight loss by fluid and sometimes energy restriction, with or without laxatives and diuretics. Unless I've missed it, I can't find any published data on that would suggest these people are systematically damaging their kidneys. One or two people are nodding, suggesting they don't know about it either. The other people you would worry about would be those with eating disorders, wouldn't you? Those with anorexia, nervosa, or bulimia, who would be underhydrated, and perhaps particularly for the bulimics, recurrently and rapidly underhydrated and then rehydrated. The difficulty here, of course, is that water depletion doesn't occur in isolation, and actually it's hypokalemia. It's low serum potassium, which is the predominant problem the eating disorder folk get, for a variety of reasons which we won't go into unless you want to. And they can actually get a type of kidney damage caused by chronic hypokalemia. So you can damage your kidneys if you have an eating disorder, but it's mainly low potassium driven. And I put this one in because I think it opens up a whole interesting area of discussion. You'll have never heard of a condition called Mesoamerican nephropathy. There's an epidemic of chronic kidney disease going on in Central America. Young men are getting kidney failure. They typically work in the sugarcane fields on the Pacific coast. They do manual labor under very hot conditions. They get chronic kidney damage. Now, they're not the only people with epidemics of this sort. There's one in Sri Lanka at the moment. There's one in a part of India. There's one in the Balkans. And most of these epidemics of chronic kidney disease in other parts of the world are in low-income settings, and they're usually due to a nephrotoxin, something which contaminates the fields, for example, heavy metals, or something called aristolochic acid. The Mesoamericans don't have those toxins. They've been looked for very extensively. And nobody knows the cause of Mesoamerican nephropathy, except the current view is that is it just recurrent episodes of dehydration? Why would it start to happen now when they've been in the sugarcane fields for 150 years? Well, they can now buy their non-steroidal for their headache at the end of the street. And nobody knows this to be true, but this is the current likely view, because most other known causes, nephrotoxins and other things, have been excluded. Does chronic underhydration aggravate? I won't talk about renal calculi or urinary infection because we covered those earlier on, but I'll come back to them. Does the choice of beverage influence kidney disease? Does it influence the kidney's ability to maintain the internal milieu? Well, I'm aware of one study in young men with acute exercise-induced hydration, 2 to 3%, in whom the amount of carbohydrate in the beverage predicted the rapidity of recovery. More rapid restitution of plasma volume, lower urine volume, lower urinary sodium, in those who had more carbohydrate in their drink. That's the only acute study I know of. Does the choice of beverage influence your chance of your kidneys getting chronically damaged? So we're into sugar-containing beverages. Now, there's a lot of interest, as most of you will know, in the question of high fructose corn syrup, which is a widely used sweetener in food and drink in the US. And pretty substantial epidemiological evidence which would associate sugar consumption with high serum uric acid and obesity and diabetes, and experimental evidence to back it up. But is it true that this actually damages your kidneys as well? The answer is we don't know, and it's because the epidemiology is inconclusive. All the data we have are from the US. They've all focused on sugar-containing beverages because they're easy to count, about 10% of US caloric intake. But the trouble is all these studies will have a different definition of exposure or an outcome. And some rely on self-reporting, some rely on proxy reporting. How much did your son drink in the way of this drink? And of course, there are many confounders because dietary sodium may influence how much beverage you drink, and clearly people who drink a lot of beverage may have different lifestyle issues. Nevertheless, although people have wanted very strongly to prove that sugar-containing beverages do give you chronic kidney disease, the truth is that at the moment we have a case control study that says yes, and a reasonably big cross-sectional study that says yes, but the biggest cross-sectional and 3 prospective studies say no. And this isn't an easy one to investigate, is it? Clearly, current consumption of diet beverages might reflect past history of sugared beverage, and nobody's been yet able to prove that diet beverages have any negative impact on kidney disease, but whether they might be a marker of past sugar beverage consumption, we're not sure. And the last question I wanted to talk about, because this is the question we're asked every day. Is there a right amount of fluid to drink if I've got normal kidneys in order to stop me getting bad kidneys? And the second question, is there a right amount of fluid to drink every day if I already have abnormal kidneys? That's the questions we get asked in clinic every single day of the week. They're, of course, 2 completely separate questions, and they're quite often conflated. And of course, the question is, and we've discussed this as the day has gone, haven't we? The question is the right amount of fluid to drink for a typical sedentary individual in a temperate climate. That's the question that's usually being asked. Now, I'm still getting confronted with the 8 glasses a day, 2.5 litres thing. In the US, I think it's still called 8 by 8, or was until recently. So it's 8 glasses a day of 8 fluid ounces. Not that I know what a fluid ounce is, but folk do. And I tried to go back and ask myself, where did this come from? Where did it come from? In 1945, the Food and Nutrition Board of the National Academy of Sciences in the US made this statement: a suitable allowance of water for adults is 2.5 litres a day in most instances, a milliliter per calorie of food. They didn't quote a primary human study, and I'd love to know the discussion as it emerges now as to whether there is a primary human study. And no, they didn't say drink 2.5 litres of water. They said most of this quantity is contained in prepared food. And on top of that, we now have the notion that you can't count alcohol or coffee in your, because it's a diuretic, so that doesn't really count. And so we're into a long and interesting discussion as to where this has come from. And because people come back to me and say, well, I've heard that it's 2.5 litres a day. So let's try and answer, what's the available epidemiology to answer this question? Does the amount of fluid a day cause kidney disease or make it worse? And there are 3 studies, and I'm going to spend a little bit of time on each of them because they're different. In the US, in NHANES, there's a study in only less than 500 people which said you were more likely to have chronic kidney disease if you were among the lowest water intake a day, less than 2 litres, as opposed to the highest, plain water intake. A study from Australia, bigger, based on nutritional questionnaires, which said the highest quintile of fluid intake, above 3 litres, lowered your risk of chronic kidney disease. And then a separate question, which is once you've got chronic kidney disease, and this is a community study in Canada using urine volume, the more you peed, more than 3 litres a day, your kidney function got worse more slowly than if you drank less. That's the sum of the evidence. Now, what happens in a field like this is that that sort of evidence comes out, people begin to be impressed by it and start telling you you're going to stop yourself getting kidney failure, and then they want to know what the mechanism is. So we now have review articles suggesting the mechanism is likely to be vasopressin, because circulating vasopressin increases in response to water deprivation, and vasopressin can be damaging to the kidney in experimental models. So we've already got a mechanism now for this effect based on some observational studies. Before you get too excited, this is the only longitudinal study we have. It was published 6 weeks ago in a European journal. A study from Australia based on daily fluid intake from food and beverages with a 13-year follow-up, and over 1,000 people had kidney function measured at least twice. The daily fluid intake was not associated at all with all-cause or cardiovascular mortality, nor was it associated with a rate of reduction in kidney function. And that's the current situation. So interesting epidemiology, all observational, plausible discussion about how it's all working, but in truth, in honest truth, no evidence at the moment for me to tell anybody with kidney disease how much they should drink to stop themselves getting kidney failure. Let me leave it at that. Thank you very much.
Thank you very much, John. Now we open to the discussion. Peter and Richard are the discussant.
Yep. Yeah. I'm the one to start. Okay. Thank you very much for this very nice presentation and very clear and still leaving us in confusion, I guess. Is there any link between hydration and kidney diseases? And you mentioned about vasopressin. I think Peter will agree with me that it's only one condition that it's almost proved that drinking high amount of water by suppressing ADH is beneficial to the patient. It's polycystic kidney disease. That the cysts go more slowly and the damage to the kidneys is really less evident. But does it matter if we have, because we are born with different kidneys, and some people have less nephrons, some more nephrons, and you can see in donors, of kidney donors, when after unilateral nephrectomy, they really have some problems after some time. Could you see any link between the amount of nephrons and the response to dehydration? Because it's kind of important thing. You mentioned less kidneys, more progression of renal disease, but less healthy nephrons leads to the same.
No, I mean, I think that's a very important difference, which is probably almost intuitive to you and I. So, but the difference between having a kidney disease which has reduced your number of functioning nephrons, and not those that are left are not necessarily working normally, is very different than simply removing half your kidney mass as a donor. So there's lots of data, because we've been doing kidney transplantation from living donors for 40 years or more, that the long-term health risks of being reduced to one kidney, if you've been properly evaluated, are incredibly small, negligible, which is why we do living donor kidney transplantation. Whereas that's a very different scenario. If you have one kidney taken out, your GFR of 100 mils per minute, 2 kidneys would in theory become 50, wouldn't it? In practice, it becomes 60 or 70 mils a minute because the remaining kidney hypertrophies. And that's a very different situation, I think, than having a kidney disease that affects both your kidneys and is taking you down to 50%. I think it's a very different scenario.
Yeah, but then we also come to this point that, especially from diabetic nephropathy, we are taught that hyperfiltration is bad for kidneys. And I couldn't find really any paper saying that really hyperfiltration is bad for kidneys. This happens in pregnancy, happens in well-controlled diabetes for years, and nothing happens to the kidneys. Could you find any data saying really hyperfiltration, it means also consuming a lot of fluid, is bad for the kidneys?
And of course, what hyperfiltration means is that at the individual nephron level, your glomerular blood flow is increasing, your individual nephrons are overworking. And of course, in most scenarios where you drink a lot of liquid, your intrarenal control mechanisms are very good indeed and will maintain your glomerular blood flow and your glomerular capillary pressure within a very narrow range so that you don't hyperfiltrate. So I suspect that's why for most, actually, if you like, most people can protect themselves from the insult of overdoing fluids.
Okay, that's fine. And then this leads me to another question. If there's a lot of, because normally when you remember from this countercurrent mechanism, the normal nephron works first concentrating and then diluting urine, the primary urine, and only afterwards comes the second concentration. So initially, everybody produces diluted urine. So the more you drink, with healthy kidneys, this doesn't influence all this mechanism, and you should be really capable of excreting all the fluid without any problems. Problem starts with unhealthy kidneys, as you mentioned, because this can progress the damage of the kidneys. But what would be the normal mechanism if the kidney is working the same way? It's not too much hyperfiltration, and then you have dehydration that decreases the work of the nephron, and you have progression of the chronic kidney disease. How you can explain this? Because this is what you mentioned. Dehydration, chronic dehydration, more progression, more fluid intake.
Well, I'm not sure I did say that because I'm not sure I believe the epidemiology at the end. Because I think it's inadequate. I'm not. The question is whether what we're describing now is purely intrarenal, although whether we're looking at circulatory effects as well. In other words, if you're chronically fluid depleted, although regardless of what's happening within the kidney, you're reducing renal blood flow, and therefore...
And oxygen. And
yes, all of those things.
Yes.
Yeah, sure.
That's obvious.
But I'm not sure I can do... I think my description was a practical description of what happens. I'm not sure I can help you with mechanisms.
No, I'm just trying to say there is no real mechanism showing it can happen unless you really are hyperperfused kidney. You get hyperperfusion,
really
which means you really need to decrease the blood inflow to the kidney. Otherwise, it's the hyperperfusion of the kidneys that is bad, not the concentration nor the lack of water.
I mean, I think that's
in your
probably
diet.
true, isn't it? And there's if you have extreme insult and you get acute tubular necrosis, and then you're likely doing yourself irreversible damage. But I think that's a very different end of the spectrum from am I quite drinking enough, or am I getting modestly dehydrated?
Well, but more, as you mentioned already, that most of our patients that appear as acute over chronic kidney disease, they are dehydrated because of diarrhea, because of vomiting, because of medications. Yeah. All this happens. Yeah. And then they recover nicely without dialysis, just with fluid replacement. Yeah. Usually with some worsening of the kidney function. And it is how you can we deal with it better than nowadays, giving just intravenous infusion? No, there are some protective measures we can also apply.
I mean, I think most of the protective measures are terribly simple and practical. They're teaching people to have a medication holiday when they get their attack of diarrhea. They're reminding family doctors and community nurses and so on that it's absolutely all right to stop those sorts of medicines. So I think that there's that bit of it, which I think, and probably if you wanted to have a health gain, you'd do that. Terribly simple. It's a matter of education and information for patients and their health carers. But as things stand, as far as I can see it, once they get into that state and get into hospital, the only sensible therapy is to restore their volume appropriately with the appropriate fluid, and then the biggest risk to them is that somebody makes a mess of the fluid replacement. Yeah. And so there's another. This is a different set of doctors with a problem.
Yeah, and then we come to this problem of hyperconcentration, immunology, and obviously it comes to cancer. Why we don't talk about cancer in kidneys, especially renal cell carcinoma?
Okay, so you're making the argument that overhydration dilutes lymphocytes, go to sleep.
Yeah,
cancer
more or less.
happens.
Yeah.
Okay.
We've spoken about this somehow. And well, what about kidney cancer and dehydration or overhydration?
Yeah, I don't think there's any evidence on. Is there at all on kidney cancer?
No, just the opposite. There's evidence there's no link between hydration and kidney cancer, but it's only one evidence that is what is protective against kidney cancer. It's alcohol. Really.
Good.
There are 3 good studies on this.
I didn't know that. Okay.
Sorry. Just curiosity, just something simple. Not to give you the ideas of getting immediate protection of the kidney cancer, no. But we've been discussing also about this stimulation and concentration in the intrarenal milieu, in the interstitial of the kidneys. And there are interstitial diseases also, and that progress very strongly with hydration, with the hyperconcentration. Do you know anything about this mechanism? This interstitial nephritis, coming from non-bacterial, obviously, non-infectious interstitial nephritis. Can we stop it somehow? And have you heard about the links between hydration and
I don't think we know directly.
Of it?
I mean, the only point I would make is that a proportion of people with interstitial nephritis are salt wasters, aren't they? So they cannot retain their sodium, so they will be chronically sodium and water depleted unless you supplement them and load them. But I'm not aware of another mechanism whereby dehydration would modify the course of interstitial renal disease. Not that I can think of, and not that I've found either.
No, that's interesting because it's a really important clinical question. Should we advise really to increase the fluid input and force diuresis with diuretics, or we should refrain from this?
I mean, I think we should be more aware of the practical clinical point that people with quite advanced kidney disease as I said to everyone, are not tolerant either way. They're not tolerant of being fluid loaded, and they're not tolerant of being fluid underloaded either. They're brittle, and they need a lot of help to get their fluid balance right. And that includes when they come into hospital. So if a patient with quite advanced kidney disease and GFR of 20 or 30 mils per minute comes in, are stable and well and come into hospital, they go to their surgical ward for their routine procedure, they're fasted and have nil by mouth until the evening, and then the operation's cancelled, and then maybe it's going to be in the morning, so they're fasted again. They're in trouble by the morning because they need fluid. They don't need overloading, but they need maintaining. So they're a challenging group of patients to look after when they're not on our own wards.
Okay, could go, but Peter also should get a chance. Sorry.
Thank you. It's clear for me that an organ which receives 25% of the cardiac output is in high risk for hypovolemia and underperfusion. So these acute situations, it's easy to explain that this could lead to reversible or irreversible damage. Irreversible because we should know that the nephrons are not able to regenerate. So, but the chronic dehydration, hypohydration, still remains a question for me because you could not show any evidence. I think the only group of patients you discussed here was the anorexia. Here I have the question, are you sure that the main factor of kidney problems of anorectic patients is due to the low fluid or this is due to a low caloric intake and the transporter mechanism which need energy for the reabsorption of sodium, etc. So the tubular transport mechanisms are damaged due to the low caloric intake.
No, it's a very good point, isn't it? I mean, yes, of course, if you take someone with severe eating disorder, then they are in bad negative protein and energy balance, and they're in trouble. And so it's a perfectly good explanation to say that in general, the kidney, since it's so important to take 25% of your blood flow, is going to be in negative energy balance and in severe trouble and isn't going to work so well in general. I think that's true. The only point I would make is that it's hypokalemia is a consistent feature, and a typical interstitial nephritis with vacuolization of tubular cells, which is the characteristic of hypokalemic nephropathy, is what you see when you do kidney biopsies on anorectics, but of course they aren't often done. Now that's based on rather small experience, because most people don't do kidney biopsies on people with anorexia nervosa, so they've got other issues to solve. But that's the available evidence.
Yeah, but I'm sure that this is due to an energetic negative balance.
I take
yeah,
the point,
and due
Peter.
to a transport
right
deficiency.
Well. Can't argue with that.
For other situations where a chronic water deprivation is the situation, I think the vasopressin theory could explain many things, and I read several papers. This is just a comment. So if someone has a low intake of water, 1.5 liter, and has an osmolarity over 280, 285, will have a constant stimulation of vasopressin. And I think that this is not just by chance. This vasopressin has a vascular effect too. So the connection between the chronic cardiovascular disease and renal disease could be really in vasopressin.
Yeah. No, I'm not disagreeing with that. I was simply, first of all, I don't think that's always going to be an observation, isn't it? And how you design an interventional study, even to prove principle that that's true. I'm sure you could, because you would need to chronically elevate vasopressin. And apart from doing that very, very artificially, I'm not sure how you do it.
Back to the acute situations where hypovolemia could occur. With these climatic changes, in Hungary, the average summer temperature was around 30, and these years we have 35, 40. And heat shock occurs quite commonly in children, and in adults. We heard about a French example with a heat wave. I think this, there are data that this could lead to acute kidney injury, but only in some patients. And in the literature, you could find data that this could be due to the, so they compared two groups of patients with exercise-associated heat shock, a group which had acute kidney injury and the other who not, and group of vasoactive factors, endothelin, angiotensin II, etc., were elevated in the first, the EHI group, and not in the other. So I think these factors could play an important role. And vasopressin was not measured in this this group. So the idea so those patients, those people who have a chronic hypohydration with this acute effect of heat shock on any acute dehydration will develop acute kidney injury, and vasopressin and other vascular factors could play a role. What do you think about this?
No, it's a very good. It's a logical explanation, but I think we're very short of any data, aren't we, which have ever measured. What you want to know is what their background vasopressin level is, and you want to know that before they have their insult, and that's your problem, isn't it? So you by the time they get in to hospital or under your care, things are badly wrong. What you really want to know is if your theory is correct, whether you can look at people's baseline vasopressin out there in the community. Does it distinguish between people who are underhydrated, for want of a better word, and that are more at risk? And I just can't quite work out how you do the study. I think it's a very interesting one.
I think we should just ask about the daily fluid intake, compare those groups. Right? Yeah, I think.
Yeah. And then I know. But then you're reliant on, when people come into hospital acutely ill, and when they're getting better, you say to them, "How much were you drinking the week before?"
It's difficult.
And by that time, 6 doctors and 4 nurses have told them they're ill because they didn't drink enough. And so what answer are they going to give you? They're going to give you the answer they didn't drink enough. So I'm not disputing the principle of the theory. I'm just trying to work out in my head how you'd ever prove or disprove that, really.
You're right. And to the question of quality of beverages, I was a bit surprised on the results about the sugar-containing beverages and the risk of chronic renal disease. The main etiology of chronic renal disease is diabetes. So in pediatrics, 20 years ago, we had no type 2 diabetes. Now, at least 10% of diabetic patients, children, are type 2. And I think this is associated clearly with caloric intake, with sugar intake, etc., and sugar-containing beverages. So I don't know. So I'm convinced that if you give sugar-containing fluids to children, they become obese, they become diabetic. The risk of developing chronic kidney disease later, this is very high. So in this prospective study, I think maybe the follow-on was not long enough to demonstrate this effect.
And I'd have to go back and read those studies again, but I think they were. I completely agree with you that there is an inevitable cycle of events of unnecessary increased calorie intake, obesity, type 2 diabetes, kidney disease. That's fine. I think what these studies were attempting to do was to answer the question whether, independent of that, there was any evidence that they were directly causing kidney damage. And I don't think we have that in a reliable way from those data. I wasn't for a moment disputing exactly what you say about diabetic nephropathy.
Thank you very much.
Thank you, John. Very high protein diets have long been popular in the athletic community, or at least in some parts, particularly bodybuilders. And there's been no evidence of any association with any harmful outcome for renal function. But of course, that's a healthy, young, relatively fit population. We're now seeing high protein diets being much more widely recommended, particularly to middle-aged, overweight individuals. Should there be any concern about those very high solute loads?
Yes. Yes. I mean, just to go back to the bodybuilder thing, first of all, there's one study I'm aware of which associated with very, very high protein loading with a particular type of kidney disease called focal glomerulosclerosis. And it's circumstantial, but it's a group of patients in the US, all biopsied, who had that disease, all of whom had been very heavy protein loaders.
Presumably also steroid users.
My memory is, somebody else may know the paper, my memory is that they weren't all they didn't admit to being steroid users, forgive me. So there's that extreme end. Some people use creatine supplements, as you well know, and I've certainly seen a couple of people who came in with very abnormal kidney function and stopped their creatine and got better. But whether that was creatine loading metabolized into creatinine, which is the main way we measure kidney function, or whether it's a true abnormality of kidney function, I don't know. But that's a long answer to your question, which was this point about what about high protein intake in general. If you start off with plumb normal kidneys, I don't think there's any particular reason to think that you're going to be getting into trouble. When you already have kidney disease, most people are talking about moderate dietary protein restriction, remembering that that means something like 0.6 grams of protein per kilo per day, which is an enormous amount of protein in half the developing world, but doesn't seem too much in North America and Europe. So it depends where you put your pitch.
But my point really is that when it was restricted to healthy, young, active individuals, we shouldn't be too concerned. But when it's now being promoted to middle-aged, relatively unfit, possibly overweight, possibly hypertensive.
Who may well have kidney disease unknown anyway. No, I think that's right. And unless I've missed something, I'm not aware of any evidence for protein loading these people. Is it going to make them live forever or stop them getting? I mean, what's the argument for giving these people high protein diets?
There's some evidence that it can help with weight loss and can help with maintenance of muscle mass during weight loss. But mostly they're energy restricted diets, and mostly it's simply a way of restricting energy intake rather than something specific to protein, I think. Protein does have a role in satiety. Ian knows much more about this than I do, but I don't think there's anything magical. Right. But we are seeing a lot of people now eating high protein diets.
And they just generate ketones because they're not eating any carbohydrate, presumably.
Yeah, thank you. Yeah, high protein diet is now discussed to be up to 30% of total energy intake, 25, 30. And this is recommended to be part of nutritional therapeutic regime. But I think here there is no evidence for an adverse effect of this amount of protein, which is double as high as we recommend. We recommend 0.8 gram per kilogram. And if we double this, we come up to that level. But I think the problem is with higher amount of protein ingested. So like the bodybuilding people, so they come up to 4 grams protein per kilogram, by the way. And I think there is, from animal models, some information about increased excretion of calcium and magnesium, and these people perhaps will have sooner or later kidney function disturbance, and this is not discussed with the double the amount we recommend, but with much higher.
And as you point out, it won't just be a matter of more protein, it'll be a matter of a lot of other things which will challenge their kidneys to balance them.
But I come back to that and say if we tell people that more protein is good for a significant number of people, more is even better.
No, we still, in nutrition science, in nutritional physiology, recommend to stay with 0.8 gram, so maximum 1 for the elderly people, so 1 gram per kilogram body weight. But in the medical world, so they come up with these recommendations, so for to increase protein, so up to double the amount, so 30% of total energy intake. I know that from diabetologists in Germany and Austria, and they are doing some intensive work now on this field.
Right. Right.
And what about the slimming diet, protein diet, to slim?
Well, if you eat protein and no energy,
Yes.
and make a lot of ketones, I guess you slim, don't you?
One group that fits that more is better thought process are strength and power athletes who take creatine as a supplement. And my read on the creatine literature is that it's relatively safe if taken with enough fluid up to a point. And of course, there were case reports early in the literature about chronic renal failure in very young athletes with mega overdoses of creatine. Has there been anything in the recent literature looking at creatine as a supplement?
I've seen it 2 or 3 times where people have come in, and it's always been reversible. It's not. It's said not always to be reversible. The few I've seen, they stopped the creatine, and measurable abnormalities of kidney function got better. I did a kidney biopsy on one of them, and there were some very minor changes. It was hard to know whether you could actually ascribe those to the creatine or not. But I think it will very likely, if you eat enough, just put your serum creatinine up and therefore lead people to the conclusion that you've got bad kidneys.
It's not very likely it does. I mean, the experiments have been done many times. You feed people 20 grams of creatine, you get huge increases in creatinine excretion.
Yeah.
So I don't think it's indicating any impairment of renal function.
Yeah.
It's simply a mass order.
Yeah. Yeah.
I was just thinking
Creatine or carnitine?
overloading
Yeah.
aspect of
Those are based on acute experiments, Ron, are they? Rather than, yes, yeah. That's it. So it's a limited experience. And the literature is pretty anecdotal and describes the same sort of thing, that people have seen 1 or 2 of these and you stop the creatine and it all goes away, or mostly goes away.
That's often because people don't follow the evidence-based protocol. So you can load in 1 to 2 weeks at 20 grams a day or something like that, but then you just need to go on to a maintenance dose of 2 or 3 grams
Right.
a day. And it will maintain the muscle creatine, but they carry on.
They go on with the loading dose. Is that right? I didn't realise that. Thanks. Ian.
But I think it does point out one of the challenges where you have markers of assessments of clinical status, whether it's 1 over creatinine or urea levels, and then you have nutritional interventions like a high-protein diet puts urea levels up, which will do. So if you just have a blind blood sample, you say, my God, something wrong with the kidneys because the urea is 7 or 8.
Yeah. And there is a bit of that, and even with creatinine, which is our standard measure, it'll certainly be put up by a meat meal, so some people are obsessive enough, at least when they're sequentially following patients, to try and have the blood sample drawn at the same time of day, for example, in order to try and avoid that. But I mean, your point's well made. And because our standard measure of kidney function in day-to-day practice is a serum creatinine, because it's easy, simple, cheap, reasonably reproducible, but like all blood tests, needs interpreting with a bit of common sense, as you rightly pointed out.
Okay, I have a question regarding the misuse of, let's say, painkillers. It's easy for me to use that word. We know from German, Austrian, and I think Swiss football players, professionals, they use, I think, 30 to 50% use painkillers just before a competition, and about 20% use them regularly before training, and some over several weeks. Do you can speculate a little bit on that? What could be the risk for kidneys?
Sure. There's irrefutable evidence that if you have a degree of kidney damage already, that non-steroidal anti-inflammatory drugs, which is mostly what we're talking about, can acutely compromise kidney function and can chronically compromise kidney function, although probably some of that will be reversible. What's less clear is if you have absolutely normal kidneys, which our guess is that most of these young, fit guys have. What's less clear is how toxic intermittent use of non-steroidals is in that setting. And I think, and my own reading of that would be is that it's not very convincingly the case. Chronic, continuous, relentless use, yes, but intermittent dosing, I would argue, if you've got plumb normal kidneys, is probably not a major risk. But as always, you're weighing that up against your career, aren't you? That's what these people are taking it.
Of course, it's in addition. Of course, we should not recommend to use the painkillers, but on the other hand, they use them. Do you think if they use them, they should drink more? Does it makes any sense? Or
I don't think that makes a great deal of difference. I mean, they've got the pharmacology on board, and I don't honestly think it makes a great deal of difference how much you drink. Some people I think will be more firm than me in saying that you just shouldn't touch these things at all. But my own experience would be that intermittent use in absolutely normal kidneys is not that dangerous.
So in contrast, it means for highly trained athletes who are used to use such drugs, probably it's very important to go to a nephrologist to identify if they have healthy kidneys. Because we had one case of a professional player. He had kidney disease, and it's a big discussion if it's
caused by, yes, sure, that's right. And you could, so was it caused by the non-steroidal, or was it just made worse by the non-steroidal? Yeah. And I could take you to 100 nephrologists, and I could get 101 different opinions on that question without any difficulty. So it's a hard one. I don't think we really know, and I wouldn't. Yes, very difficult to prove.
Okay, and finally to this Mesoamerican nephropathy, it's very interesting, but it's just anecdotal. I saw a documentary that in some countries, especially for banana production, for example, they go over the field and just give pesticides. So could it be something like that? That in, let's say, in Central America, they use different pesticides for that?
Because of experience in other similar epidemics in other parts of the world, when the Central American epidemic started, they made a very concerted effort with. They got nephrologists and pathologists and epidemiologists and agricultural people together, and they looked very carefully, and they couldn't find a pesticide or similar nephrotoxin. I think they started with the assumption it was going to be that, particularly because it appeared to be new, and therefore the most likely thing would be that somebody started spraying something else on the fields, but they can't find it. That's what's interesting and surprising. And whether this story that it really is due to recurrent dehydration will play out, I'm not sure, but I think it's just a very interesting one.
I've got quite a simple question, really. I mean, how can somebody know if they're in the early stages of kidney disease? You mentioned before that someone may not know.
Sure.
And if they did know, would paying better attention to their hydration status help to prevent any further damage?
Okay. No, I don't. Well, there are two bits to the question, Jane. So the first is quite right. Most people with a kidney disease, which is slowly progressive, have no symptoms in the early stages, and they will typically be picked up because somebody tests their urine, because there's often blood or protein in it, but not always, because someone measures their blood pressure, because of the link between blood pressure and kidney disease, or someone does a blood test for some other reason and stumbles on it. So those are the commonest ways it be. I mean, some people swell and get other things, but that's the common scenario. And the second bit of the question is there any evidence that hydration status in general makes a difference or should be recommended? I think on the available epidemiology, I would say no. At this point, there is none. And that would be my opinion. And clearly, there will be exceptions. There will be people who will be drinking remarkably little and compromising themselves. But for the average person with a typical fluid intake, I don't think I'm convinced there's any evidence that I should go around telling them to drink more fluid. The one specific exception, which Richard mentioned, is this condition, polycystic kidney disease, where the cysts in the kidneys relentlessly grow. And there's some evidence that high fluid intake will slow that process of cyst growth. But it means a lifetime of high fluid intake and seriously high fluid intake.
But you don't have any data saying that big fluid intake is bad for kidneys.
Correct.
As
far as I'm concerned, there are no such data. That's my opinion.
I have a vague memory somewhere that there may be differences in the prevalence of renal disease in different ethnic groups. Am I mistaken?
No, it's true. So a couple of aspects to that. The first is that because diabetes is more common in some ethnicities, therefore diabetic kidney disease is more common. But it's actually more than that. So in my own city, in Leicester, where we have a large South Asian population, if you're South Asian and have diabetes, you're 10 times as likely to get kidney failure as if you're white and have diabetes. So there's something about that group. But you could look around the world, and it's similarly, if you look at African Americans, they're more likely to be on dialysis and transplanted than whites. If you look at South Asians, and in fact, it's probably the other way around, actually. In other words, what is it about white Europeans which uniquely protects them from kidney failure? Because they seem to be the racial group least susceptible.
Are you going to tell us?
No, nobody knows.
Oh.
No.
But there's a tenfold difference,
There's
and
a tenfold
nobody
difference.
knows.
There's a tenfold difference. We know remarkably little about it. We don't know the genetics of it. I think one of the questions is clearly genes or environment or both. We don't know the genetics of it. And the environmental question is an interesting one because most of the Asians who've come to my city came 2 generations ago. They came 40 years ago. And yet there's no sign of that falling off, suggesting that it might not be environmental. But I don't think we know the answer to the question, but there are all sorts of interesting things in there. If you just look at diabetes without the kidneys, I know it's not what I'm meant to be talking about, but if you look at diabetes without the kidney disease, and you look at the growth in diabetes, which is happening all over the world, if you look at developing country, urban environments, look at Manila or look at... the growth is 2-3 times as fast as it is in white Europeans. Now, whether that's genetic or whether it's that we've taken 200 or 300 years to move from to the sort of plenty we have in the way of nutrition, yet they've done it in 2 generations. I'm looking at Ian because I don't know anything about this. I'm talking my feet, really. So those are very interesting questions to unwrap. Nick, it's a long discussion, probably slightly outside my brief, sorry.
Okay, just a small comment on this Mesoamerican nephropathy. In February, I guess, the Sri Lanka president banned using Roundup from Monsanto, a herbicide, because this is linked to this nephropathy along with hard water. This herbicide with hard water, kidney disease, and now this is the most modern, I think, idea. But all the other, I'm not saying this is the only explanation. It's just something quite on because of Monsanto. It's quite hot.
Well, there are epidemics of chronic kidney disease which look similar clinically around the world. People have shrunken kidneys with interstitial fibrosis and so on. And some of them are undoubtedly appear to be very clearly pesticide linked. Some of them seem to be aristolochic acid, and some of them aren't. So I think what you learn from that is that, like many organs in the body, the kidney has a limited number of ways of demonstrating that it's unhappy. And because you get a kidney disease that looks clinically the same in 2 different places, don't assume it's got the same cause, because there are a limited number of ways in which a kidney can hold up its hands and say I'm sick.
Not at all. But can I come back to this people with hyponatremia? Isn't it quite obvious, and this data from biopsies in patients, isn't it quite obvious that in hyponatremia, chronic hyponatremia, hypopotassiemia is something, hypokalemia is absolutely present and very not only frequent, it's obligatory almost because of physiology, and then accompanied frequently by hypomagnesemia. Because when you look at this prescriptions, how to correct hyponatremia, hypokalemia has to be corrected immediately with the data, and hypomagnesemia as well. So it's chronic, obviously, chronic hyponatremia.
No, you're correct. I mean, it's almost impossible in these situations to take out one factor, isn't it? And say, this is just caused by a low serum sodium, this is just caused by a low potassium, and so on. They are inevitably bound together, just because of the way the tubule handles solute. You're never going to separate those.
And just for the clarity of what we are talking about, the volemia, because we are talking hypervolemia, hypovolemia. Is it important the blood volume or just the effective blood volume in the big arteries? Because as far as I understand, the venous part is just is very important, obviously, but is much more under the sympathetic nerves and this autonomous nervous system. And this is just putting blood, more blood, less blood. But what is important for kidney health is the effective blood volume.
No, I completely agree with you, and that's why I put the term effective circulating volume on my slides. And it's almost a conceptual thing. I'm not quite sure how you measure effective circulating volume, except it's that bit which is absolutely relevant for kidney perfusion. I agree with you completely.
Okay. Don't want to talk too much.
Is there any other question?
I wonder what your views are on urine output as a measure of kidney health. I am aware that I think it's the Renal Society that recommend all the guidelines of acute kidney injury, less than 0.5 ml per kilogram per hour for 6 hours. I wonder what your views on that.
So I think it absolutely depends on the setting in which you're asking the question. So if you're asking the question of somebody who's acutely ill, who's come into hospital, whose kidney function appears to be deteriorating based on a blood test, and they are oliguric, their urine volume is very low, then that's a contributing piece of information which says that patient's at very high risk indeed of getting acute tubercular necrosis and needs to be managed in a certain way. I think if people already have chronic kidney damage, as I tried to hint to you, these people, as their kidney disease advances, have isostenuria, they have fixed urine osmo, they tend to have a fixed urine volume, and it's a very bad measure of kidney health because it tells you that they're fixed. The other question is, so the question is in what setting urine volume gives you a measure of something that you want to know, and going away from volume to hydration state, the question is whether a measurement of urine output gives you a measure of hydration state. And the trouble, I'm not trying to duck the question, but there is, in the clinical situation in which you look at that, there are so many variables. So I think I kind of pick up on the conversation we had earlier when you were talking. By all means measure that, but do a few other things as well. And that includes examining the patient before you do a blood test. You go to the bedside, you look at the blood pressure, you look at the patient's clinical circulating volume, you look at their edema, you look at their traditional measures of hydration, and you look at some blood tests, and you look at a urine volume, and you make a global clinical assessment of where that patient's volume and hydration are. And I think that that's difficult because it's subjective and difficult to write into trials, but if you're asking how to care for the people, that's how you do it. And taking one thing on its own always worries me.
So if there are no more questions, maybe you would like to make a last statement?
Last statement. I'll make do you want me to make I'll make a last statement.
Make a last statement.
Okay.
Like
I think
last sentence.
I'll say a couple of things I didn't say on the slides. Overall, I think in people with chronic kidney disease, there's no evidence that the amount of fluid you drink makes any difference to your outcome. There are 2 or 3 chronic circumstances where it is relevant in this field. One is polycystic kidneys we've discussed. 2 is the thing which Ahmed discussed a bit as well, which is kidney stones, where there's very good evidence indeed that the only thing that matters is the amount of water you drink, regardless of what the metabolic problem that causes your kidney stones. And those are probably the 2 where we got convincing evidence. Even, although I didn't review it in detail, even the thing which I've been doing for 30 years, which is tell every woman with recurrent cystitis that she must drink more water because she'll get less urine infections, in women, actually is not supported by very much evidence at all. It's complete part of folklore. I couldn't stop myself doing it. I've been doing it for 30 years. But actually, but I'll rephrase that. There is little evidence because actually the studies are not very good. Everyone's taken it for granted and nobody's ever done it. So So that's that.
So there is still hope. Eh?
There's still hope. And I suppose my last message is on my second or third slide, which is I think that we just need to sit back and remind ourselves of definitions of volume, definitions of hydration, and reminding people who aren't in the field and at the bedside every day what hypo and hypernatremia actually mean, and going and somewhere in whatever guidelines we develop, talking about the clinical principles of fluid and volume assessment, not just a test. Yeah. That would be a view. Okay.
Okay.